Thank you, Mr. Chairman. I'm going to talk about focal hepatic lesions in non-cirrhotic liver. Focal hepatic lesions can be divided into 4 groups, and I would like to some typical and atypical examples of the focal hepatic lesion. First of all, I would say that we have to remind the basics of image interpretation. Image interpretation is based on morphology, MR signal intensity or CT numbers, and enhancement characteristics. MR signal intensity or CT numbers are important for tissue characterization, and enhancement characteristic is really important for differential diagnosis, especially for focal hepatic lesions. Let's move on to the first group, cystic lesions associated with ductal plate malformation. Hepatic cysts are common lesions in the liver and usually can be divided into unilocular or multilocular varieties, and it is lined by cuboidal epithelium surrounded by fibrous stroma and contains serous fluid. It often complicated by hemorrhage or infection. MR imaging is particularly valuable when lesions are small and the patient has a history of primary malignancy. It is a common problem when we see small low attenuating lesions detected on CT. In this patient with colon cancer, we can see a metastatic lesion in segment 4 of the liver. However, it is not easy to characterize small low attenuating nodules on CT. However, we can distinguish cystic lesions from metastatic lesions using heavily T2-weighted image and diffusion-weighted imaging. This is an example of a cystic lesion. We can see a cystic mass with internal septation and intramural nodule. Contrast enhanced CT show cystic mass with enhancing mural nodule. The patient underwent catheter drainage under the impression of complicated cyst. However, the lesion, solid portion of the lesion increased in size within 1 month, and the patient underwent surgical resection, and the pathology proved embryonal sarcoma of the liver. Therefore, we have to be careful in evaluating cystic lesions with solid portion. This is another example of a cystic lesion. As you can see on ultrasound, we can see a bright dot scattered in both lobes of the liver. This finding may be confused with the chronic liver disease. However, it is more clearly seen innumerable cystic lesions on heavily T2-weighted images, and the lesion is a characteristic feature of biliary hamartoma. Biliary hamartoma is a benign biliary malformation, and it is thought to the part of spectrum of fibrocystic disease caused by ductal plate malformation. It consists of a collection of innumerable small cystic lesions in the liver, and the differential diagnosis include metastasis, microabscess, and Carolus disease. It may show thin enhancement on delayed phase images. However, there is no centripetal progression of enhancement, which is different from metastatic lesion. This is a graph showing ductal plate malformation. During the early stage, there is a single ductal plate surrounding the portal vein, followed by formation of double-layered ductal plate. Extensive resorption leads to the network of the bile duct. When there is insufficient resorption of the ductal plate, leads to the cystic dilatation of the biliary segment. This is another example of a ductal plate malformation. This patient has enlarged kidneys and innumerable cysts that replaced both kidneys, and we can see peribiliary cysts. Peribiliary cysts are thought to be cystic dilatation of the peribiliary glands of the intrahepatic duct. Peribiliary glands are located in both sides of the portal triad, whereas cystic dilatation of the bile duct is present in only one side of the portal vein. Moving to the second group, inflammatory and infectious liver disease. Inflammatory pseudotumor is often difficult to diagnose because of its non-specific imaging findings. As you can see in these images, there is an arterial enhancement and ISO signal intensity on polar and delayed phase images. T2 signal intensity is not specific. The patient underwent hepatic dissection and the pathologic diagnosis was inflammatory pseudotumor. Inflammatory pseudotumor is composed of myofibroblast and lymphocytic infiltration. A subset of the inflammatory pseudotumor is a reactive pseudotumoral process, and another subset is a true mesenchymal neoplasm of the myofibroblast. As you can see on this diagram, there is an overlap between inflammatory pseudotumor, inflammatory myofibroblastic tumor, and IgG4-related sclerosing disease, such as autoimmune pancreatitis, retroperitoneal fibrosis. Imaging finding is non-specific. However, some of the inflammatory pseudotumor looks like cholangiocarcinoma. This is an example of pyogenic abscess by Klebsiella pneumonia. Cluster sign has been known to be the helpful sign for diagnosing hepatic abscess. However, Klebsiella pneumonia, pyogenic abscess by Klebsiella pneumonia is a little bit different from typical pyogenic abscess. We can see turquoise sign, hairball sign, showing the amorphous hair-like content in the cystic fluid and breakage of the septum, and it looks like a turkey stone. We call this a turquoise sign. This is another example of hepatic abscess. It looks like cholangiocarcinoma. However, there is quite different imaging features of cholangiocarcinoma and hepatic abscess, because usually central portion of the cholangiocarcinoma show low attenuation because of abundant fibrotic tissue. The patient underwent ultrasound-guided biopsy, and pathology revealed that hepatic abscess, the lesion has decreased on follow-up CT scan. Hepatic tuberculosis is often difficult to diagnose because of its non-specific imaging features. It can be divided into miliary form and local form. The signal intensity of the granuloma depends on caseating or non-caseating stage. This is an example of hepatic tuberculosis. The patient had a history of breast cancer. As you can see on CT, ill-defined nodules are seen in right lobe of the liver. Dynamic enhancement images show peripheral ring-like enhancement, which is similar to the findings of hepatic metastasis. And the patient underwent ultrasound-guided biopsy, and it proved to be a hepatic tuberculosis. What about this case? This is a case of focal eosinophilic infiltration. We can see a nodule in the dome of the liver. It has a fuzzy margin, and hepatobiliary phase images show mixed signal intensity and slightly hyper intensity on T2 weighted images. Surgical specimen show the focal eosinophilic infiltration. The morphology characteristics of focal eosinophilic infiltration is a non-spherical shape with a fuzzy margin, and hepatobiliary phase images can be helpful for showing mixed ISO and low signal intensity. This is another example of a focal eosinophilic infiltration. Sometimes eosinophilic infiltration resemble the infiltrative tumor of the liver. Moving to the third group, benign tumors, hepatic hemangioma is the most common benign hepatic tumor, and it is a well-circumscribed mass of blood-filled spaces lined by endothelium. Thrombosis, calcification, fibrosis, and scarring may occur. Three enhancement characteristics have been established. Small hepatic hemangiomas usually show immediate uniform enhancement, and the most common enhancement pattern is peripheral nodular enhancement with centripetal progression to uniform enhancement. And giant hemangioma may show persistent central scar. This is a typical enhancement characteristics of hepatic hemangioma. And T2 weighted images show bright signal intensity similar to that of bile juice or CSF. Sometimes peritumoral enhancement may be seen in the hepatic hemangioma. Peritumoral enhancement is more common in hemangiomas with rapid enhancement. Sclerosed hemangioma is a predominantly fibrotic hemangioma with near completely obliterated vascular spaces. Sclerosing hemangioma is a partly affected hemangioma, which is thought to be arise from cavernous hemangioma. This is an example of a sclerosing hemangioma. We can see ring-like calcification and poor enhancement. T2 weighted image show bright signal intensity similar to that of CSF fluid. FNH is a lobulated, well-circumscribed hepatic lesion, and it is considered to be the hyperplastic response of the hepatic parenchyma to a localized vascular abnormality. It consists of a hypervascular, hyperplastic hepatocyte and bile ductures, malformed bile ductures surrounding central scar. Arterial images show homogeneous enhancement, and important finding is hepatobiliary phase images. Most of the FNH show iso or hyperintensity on hepatobiliary phase images. As you can see in these images, the FNH show iso signal intensity on pre-contrast images. Arterial phase images show strong homogeneous enhancement and central scar. Hepatobiliary phase images show bright signal intensity and central scar. However, some of the FNH show heterogeneous uptake of the hepatobiliary contrast agent, and central scar may not be clearly seen on T2 weighted images. Hepatic adenoma is related to the use of oral contraceptive and anabolic steroid and glycogen storage disease. T1 weighted images may show hyperintensity due to glycogen or fat. Necrosis and hemorrhage are frequent. As you can see in these images, intratumoral hemorrhage are frequent finding of the hepatic adenoma. What do you think about this case? As you can see in these images, we can see a mass in the right lobe of the liver. The mass is clearly depicted on opposed page images due to surrounding fatty liver. Iso signal slightly hyper intensity on T2 weighted images, homogeneous arterial enhancement, and iso signal intensity on delayed phase images. However, we can see a small washout area, and the pathology reported that the lesion was hepatocellular carcinoma arising from hepatocellular adenoma. Angiomyolipoma is a benign mesenchymal tumor with a mixture of fat, smooth muscle, and blood vessel. If there is a small foci of fat component, we can make a correct diagnosis. However, when there is no fat, it's not easy to make correct diagnosis of hepatic adenoma, hepatic angiomyolipoma. Hepatic pseudolipoma is a degenerated fat encapsulated by hepatic capsule, and it is regarded to be arise from colonic appendage, colonic epiploid appendix. Moving to the final group, hepatic metastasis is supplied by hepatic artery, and important point is that some of the hypervascular metastasis may show hyperintensity on T2 weighted images, such as neuroendocrine tumor, sarcoma, melanoma, thyroid carcinoma. Typically, metastatic lesions show peripheral limb-like enhancement. However, some of the tumors may show bright signal intensity on heavily T2 weighted images. This is the case of multiple metastasis from neuroendocrine tumor in the pancreas. Some mucinous metastasis may show bright signal intensity on heavily T2 weighted images, and hyperintense lesions include the leiomyosarcoma.
1 more minute.
Sometimes cirrhosis-like patterns of metastasis may occur from breast cancer. This is an example of hepatic lymphoma. In my final case, there is a mass in the right and left lobe of the liver. The enhancement pattern is quite bizarre, and some of the areas show ring-like enhancement and centripetal enhancement, heterogeneous enhancement on T2 weighted images. This is a case of angiomyosarcoma. It is a malignant spindle cell tumor and forms poorly organized vessels, and differential diagnoses include hepatic hemangioma, metastasis, and hepatocellular carcinoma. Coming back to the first slide, MR signal intensity, CT number, morphology and enhancement characteristics are really important for differentiating focal hepatic lesions. And focal hepatic lesions can be divided into 4 groups. If you're familiar with the typical and atypical imaging findings of the focal hepatic lesion, we can make a correct diagnosis. Thank you for your attention.